We will have questions after the panel.
Thank you. Well, thank you. This process of developing these recommendations has really been a fascinating one. In many ways, it was an intersection between the science as we understand it, healthcare and clinical practice as it is today, and where it might go, and then how to shoehorn these strains into policy recommendations, which a very diverse coalition and the alliance membership could get behind and endorse. And I think at the outset we had some reservations, let's say, or issues as to whether we could pull off this process. But I have to say, I think everyone involved in this was so enthused about what's going on in this town, even as we speak about significant changes coming in the healthcare system, and an opportunity to really make some serious investments and recommendations that we think have good potential to be achieved. And just to underscore that, I don't know if you noticed during the summer when President Obama was in Portsmouth, New Hampshire, but he had a very succinct statement that he did not understand a healthcare system that paid nothing or a pittance for counseling on obesity or diabetes, and then tens of thousands of dollars for amputations down the disease pathways. And so hopefully in the next few hours we will continue he will continue that orientation. Congress will continue to look at what they're working on in that vein. And I think our recommendations fit very appropriately into that. We're going to, I'm going to have the panelists who've already been introduced go through this. I just want to say one thing about our panelists and being here with Dr. Satcher and Dr. Carmona. I'm used to seeing or think of Dr. Satcher and Carmona in their public health service uniform. So when I see you in civvies, I'm always a little taken aback. But I also kind of think that for folks who have been through healthcare policy debates in Washington over the years, that civilians ought to get like campaign ribbons that they have in the military. You know, I survived the Clinton healthcare plan. And if we had that, I think this table would look like the meeting of the Joint Chiefs of Staff. These folks have been through many, many battles, many years, and have a wealth of experience, not just in obesity, but in other related areas. So with that being said, I'm going to ask Joe Nadglowski to lead off and talk about the first recommendation we have, which is a big one in terms of coverage of obesity treatments. Joe.
Thank you, Morgan. Thank you, Christy, for inviting me to be here today. I am going to talk about a topic that doesn't attract as much attention as obesity prevention does, which we'll talk about in a little while, but that is access to obesity interventions or treatments. The reality is that 1 in 3 Americans are already obese. 2/3 of us are overweight or obese. And the reality is we need intervention for these folks as well as prevention. And so the Stop Obesity Alliance has come forward with a number of recommendations. Christy outlined these briefly. I'll repeat it, though. Basically that we need standardized and effective clinical interventions flowing from evidence-based guidelines, such as those approved by the National Heart, Lung, and Blood Institute, that include acknowledging the health benefits of 5 to 10% sustained weight loss, and support those individuals who are currently overweight or obese to achieve improved health. You know, the question we often hear from folks is, well, how do we treat obesity? You know, what are the guidelines? And the reality is the NIH through the NHLBI has put forward those guidelines. They did so in 1998. They are very comprehensive, include a number of interventions, and individuals should have access to those. The harsh reality is that the vast majority of us in this room, unless you happen to work for a very enlightened company, do not have the ability to walk in to your doctor's office and receive treatment for your obesity. It is almost always excluded. And that is a challenge. If this is the biggest crisis we face as a country, is that correct? Just because obesity treatment is hard does not mean that we should not try to do it. And the reality is that maybe we've set our expectations somewhat too high. If someone is obese, is our goal to return them to a normal weight? Of course, in an ideal situation. But the reality is that the evidence shows that it only takes 5 to 10% weight loss to achieve improved health, to reduce the prevalence of type 2 diabetes, and to reduce cardiovascular effects. And the guidelines or the recommendations made by the Stop Obesity Alliance outline that. It's also important to bring up the reality that most physicians do not talk to their patients about their weight. And Dr. Carmona mentioned this in his opening comments, that because there is a stigma around obesity, they don't want to have that conversation, or it could be because there are a lack of options they feel as if they could bring forward. But the reality is we need to, in any type of reform, encourage physicians to engage their patients in those conversations. The reverse is true as well. We need to encourage individuals to start that conversation with their doctor. We also need to make sure that physicians and other healthcare professionals are adequately trained to address obesity. The reality is that is not taking place, and we need more action specifically around training those healthcare professionals. And finally, we need to make sure that the guidelines are continually updated. As we know, new interventions are coming about nearly every day. As Christy mentioned earlier, one of the recommendations will be around research. We need to make sure as that research takes place and those interventions, new interventions come about, that individuals have access to them in a timely manner. In fact, we know that the NIH group is currently reviewing the obesity treatment guidelines, and I think in the short order, in the spring of 2010, we will see new obesity treatment guidelines. And in my mind, and what I advocate for when I'm here in Washington every week talking to legislators, is that when those guidelines are produced, that individuals will have access to those guidelines and have access to those treatments so they can, when they are ready, make a difference in their lives. So Morgan, I'll turn it back over to you to have the other recommendations.